Hello, I'm Sergio Giralt, Deputy Head of the Division of Hematologic Malignancies at Memorial Sloan Kettering Cancer Center, the Melvin Berlin Family Chair of Myeloma Research, and Professor of Medicine at Weill Cornell Medical College. It's a true pleasure for me to join you today and talk about why we need better myeloablative conditioning regimens for multiple myeloma. It's now been more than 30 years since Professor McElwain and Professor Powles demonstrated that high-dose melphalan could achieve long-term remissions in patients with myeloma who had failed standard-dose melphalan, demonstrating that there was a dose response in myeloma patients for high-dose melphalan. It was Dr. Bart Barlog who showed that stem cell support could make high-dose melphalan much safer by providing a mitigation strategy for the myeloablation and the neutropenia or the myelosuppression that would occur after high-dose melphalan therapy. The French did a randomized trial comparing high-dose melphalan to melphalan in combination with total body radiation and failed to show an advantage for the more intense regimen of melphalan and total body radiation. Thus, for more than 20 years, melphalan 200 milligrams per meter squared has been the standard for autologous transplant conditioning regimens. We and others believe that there has to be better ways. Initially, the Australians have shown that there is a significant variation in melphalan drug exposure amongst patients who get fixed dose of melphalan 200 milligrams per meter squared. However, standard melphalan, i.e. Alkeran, is unfortunately very unstable and is rapidly hydrolyzed, and thus PK-directed therapy is somewhat difficult to do. However, propylene glycol-free melphalans, i.e. Evomela, is much more stable. Dr. Gunjan Shah at Memorial Sloan Kettering has shown that PK-directed therapy with Evomela is possible, and we can get 80 to 90% of the people to have an exposure of around 13 micromole per minute. And thus, we are now exploring PK-directed melphalan as a way of ensuring that patients get the appropriate melphalan exposure. New drugs have become available, though, and one of these is OP-501, which is a derivative of melflufen. Melflufen is an alkylating agent that, in the presence of aminopeptidases, is concentrated in malignant cells. Myeloma cells, plasma cells, have high levels of aminopeptidases, and thus it seems logical to think that OP-501 may be a better conditioning regimen, and this is now being explored in phase 1 trials. The University of Texas MD Anderson Cancer Center has done a randomized trial of busulfan melphalan versus melphalan alone, and has shown that a more intense regimen of combination of busulfan and melphalan was associated with higher response rates and better progression-free survival, but not improved overall survival. It is interesting to show that there are other strategies that are now potentially being explored as conditioning regimens for myeloma, amongst them targeted radio-immunotherapy with actinium or CD45 radio-immune conjugates. One would expect and hope to see CD38 targeted radioimmunotherapy, BCMA targeted radioimmunotherapy as other strategies to be explored, although these have not yet arrived in the clinic. In summary, we expect that over the next 5 years, there will be new strategies to provide or to exploit the dose-intense phenomena that we know is important for long-term disease control in myeloma. It is a way of eliminating resistant clones that have emerged during the journey of the patient. Thank you very much.